Today, in this session, he will speak about surgical challenges in MICS CABG.
Hi, good evening. I want to begin this presentation with some great personalities. We all recognize them, but we don't know about their struggles, the challenges they overcome. Everyone we know him, his name is Steven Spielberg, American film director. Rejected twice by the University of Southern California's School of Cinematic Arts. Struggled with dyslexia, which made it harder for him to cope with school. After that, he won 11 Emmys, 3 Oscars, 7 Golden Globes, and he is one of the most successful men. The same school built a building in honor of Spielberg. Albert Einstein, the German theoretical scientist, did not start speaking until he was 4, reading until he was 7, and was thought to be mentally handicapped. But he went on to win a Nobel Prize, altered the world's approach to physics. Now his name is synonymous with intelligence. We know him, everybody in the hall, we know him very well. Mark Zuckerberg, the Facebook founder, dropped out of Harvard in his sophomore year, co-founded Facebook, CEO of Meta with a net worth of 1.26 trillion USD. So, the pain you feel today is the strength you feel tomorrow. For every challenge encountered, there is opportunity for growth. Today, my talk on surgical challenges in minimal invasive CABG. Surgical challenges in minimal invasive CABG is, number 1 is patient selection, exposure problem and limited access, lima harvesting, proximal anastomosis, distal anastomosis, intolerance for single lung ventilation, and of course, psychological challenge. I always told my students, every step of MICS CABG is challenging. I always avoid this kind of patients. Now, exposure problem and limited access, I always try to overcome by proper positioning of the patient. Already I told in my morning session presentation, I always try to keep my patient semi-right lateral decubitus position with the left arm extended, avoiding any traction to prevent brachial plexus injury. Higher access routes can be impair exposure when performing RCA system anastomosis, while lower access routes can create difficult in proximal anastomosis. Surgeon should be flexible in changing the intercostal space to one space above or below, if needed, all through the same skin incision. Adhesion of either the pleura or the pericardium should be carefully ablated. Before incision, we think about that double lumen ET tube must be ensured. On the left side, CBP and radial ulnar lines on the left side, external defibrillator pads, left chest up to 30 to 40 degree, and MICS instrument should be ensured. Before incision, I will show you a short video. You can see the positioning of the patient position in 30 degree, already I have said. Leave the sternal excess for emergency sternotomy. Leave femoral excess for emergency fem-fem bypass. Mark your incision and landmark. I always try to keep the incision in case of men just below the nipple, and you women below the breast along the inframammary crease, and it coincides with the X-ray. During insertion of triangular thoratract retractor blade for Lima harvesting, to point towards the right shoulder, rather it should point more towards left mid-clavicular line to prevent Lima injury. Here the short video of the Lima harvesting. The Lima can be found medial to the intercostal space incision. Lima may not be visualized as a whole. Better to start where it is seem more prominent and clip and give the cautery to the Lima harvesting. So the proximal anastomosis is another challenging. Pericardial fat, already the Rajneesh told that pericardial fat on the anterior surface is excised to allow for better exposure. Pericardium is opened gradually towards midline. Use gauge piece over the RA to avoid the RA auricle. We use sealing near aortic root, gentle traction. Vascular clamping can be further retake the ascending aorta. So now here you can also see the proximal anastomosis by 6-oprolin. There are two anastomosis and the flow of the vein. The distal anastomosis exposure relies upon pericardial retraction and the use of a tissue stabilizer. Use of octopus novo, already Yusuf said, and starfish, but I always prefer to use the normal stabilizer. Use of deep pericardial sealing, manipulation, the direction of snare, and the pericardial stay suture for the facilitate the exposure. Use of conventional stabilizer. Now for the distal anastomosis, pericardium T-shape, pericardiotomy, I always try to do the T-shape. Open bilateral pleura, deep pericardial stage. Most of the cases I used to need to do. Stabilization device and longer instruments. For LAD and diagonal anastomosis, deep pericardial suture towards the left. I always pull the deep pericardial suture. Gauze piece to the left, lift to the heart. Use. WM 1 and 2, same the deep pericardial suture to left shoulder. Free the right pericardial suture. Handling the heart for selecting the grafting site can be done safely with 2 peanuts. Here is a short video of distal anastomosis for using the normal stabilizer, shunting to LAD, Lima to LAD with 7-oprolin. Then Lima to LAD graft. Now the venous graft in diagonal with the 7-oprolins, and third one in the OM, off pump beating heart, Lima RSBG2 OM. We also use the 7-oprolin. So there are 2 proximal and 1 Lima to LAD, 3 grafts. The case number 1, Jet, 48 years male, hypertensive, diabetic, EF 44%, and the graft plan. What is the graft plan? This is the angiographic view. We did 4 grafts here. You can see the 3 proximal, Lima to LAD, Lima to LAD, RSBG to diagonal, RSBG to WM1, and RSBG to PDA. There are 4 grafts. Now, take-home message is minimal invasive CABG is a challenging procedure with numerous hurdles that can be overcome. Adhering to meticulous surgical techniques can help avoid some of the major concerns we encountered in this procedure. If you can ensure the optimum revascularization without compromising the quality of the graft, minimal invasive surgery should be on the top of the list of choice. The reasonable man adapts himself to the world. The unreasonable one persists in trying to adapt the world to himself. Therefore, all progress depends on the unreasonable man. So, everyone, we should take the challenge. Inshallah, one day we'll win it. Thank you all.